My name is Misty Blevins with the National Rural Health Association, SC. I want to take this opportunity to welcome each of you to today's webinar, Diving into Telemedicine, Adventist Health's Virtual Care Network. We are unable to provide CEUs or CPEs for this session. Certificates of attendance will be available upon request for attendees who register, attend the entire webinar, and participate in the post-webinar survey. Attendees may use these certificates with third-party organizations or their employer as documentation of having received an hour of webinar instruction. NRHA partner educational webinars are recorded, and an on-demand link will be sent in 24 hours to all who registered for the live webinar. Please note that throughout the presentation, all participants will be placed on mute. If you need to communicate with the webinar organizer during the session or have a question for the presenter, please use the question box at the bottom of the GoToWebinar control panel. We will answer questions after the webinar. I would like to offer a warm welcome to Carrie Dostie with AMD Global Telemedicine, a National Rural Health Association Platinum Partner.
Thank you, Misty. And welcome everybody to today's webinar, Diving into Telemedicine. As Misty mentioned, we are going to save the questions for the end, and if you do have questions along the way, anytime during the presentation, feel free to type the question into the box on the right-hand side of your control panel, and we'll address each of the questions at the end. And the ones we don't get to, feel free to reach out to the presenters with questions or myself. For webinar technical support, if you run into any issues, you can call 1-800-263-6317. So today's featured presenters will be Dan McCafferty, the VP of Global Sales and Corporate Development with AMD Global Telemedicine, and Rob Marchuk, the Vice President of Ancillary Services at Adventist Health. So today we're going to cover the key factors to telemedicine implementation and walk you through some important items to consider when you're putting together your telemedicine program, and the importance of interoperable technologies so you can understand how all the different technologies, healthcare technologies and telemedicine technologies can work together and really help you optimize your program. And then we'll hear from Adventist Health about their virtual care network and how they got started with their program and the success they've had along the way. So I will turn it over now to Dan McCafferty.
Thank you, Carrie, and thank you everyone for attending. To help us focus what we speak about, when I say we, Rob and I, we'll ask just a few poll questions along the way so that you can help us to guide the discussions into areas that are most pertinent to the participants. So the first poll question is a simple one. How many of you currently have a telemedicine program, yes or no? So I'll give just a few moments for people to respond to that. That'll help us to guide the discussions. Okay, terrific. So we see that by and large about 2/3 of the people on the that are participating have indeed some form of telemedicine program running, and about 1/3 don't. So that's terrific. Thank you for that help. Now, let's define a little bit of a term here so that we can focus in on the types of technology that are being deployed at Adventist. The telehealth spectrum, or the word telehealth, can mean so many different things to so many people. Here's a general graphic of a typical healthcare scenario. You have a medical event, and there's a clinical assessment done. That assessment leads to either outpatient care or inpatient care. The inpatient care could require surgery, but then eventually, as in outpatient care, the patient returns home where they may even encounter some monitoring or mHealth technology. Now, there are many companies and many technologies out there that cover all different facets of these different steps. Today, we're covering clinical telemedicine. It's the type of techniques and technologies that Adventist and AMD have deployed to evaluate a patient from afar to make that decision regarding is this an inpatient or an outpatient event that needs to be treated? Okay, so we're focusing on that first step, not necessarily home care and monitoring and mHealth. Now, that being said, that technology, just because it's focusing on the clinical assessment, doesn't mean that's limited in any way as to where it could actually occur. All the things that we'll be talking about today, whether it be technology or from AMD or technique from Adventist, can all be used in all these different areas. Typically, the difference between how telemedicine, clinical telemedicine now is deployed in these different areas really just varies by the types of medical diagnostic devices you may need in order to treat the patients in these different environments. If you look at a rural clinic and what they may need to be self-sustaining to do a hub and spoke model back to a hospital, you may need devices A, B, C, G, and H. If you go to a long-term care facility or a skilled nursing facility, that device list may and will be different. So it's really just a matter of understanding the needs of the patient and the types of patients, the types of things you will encounter and will want to evaluate and treat, and make the appropriate decisions on what you need. That being said, the underlying communications technologies, the underlying EMR integration technology, video conferencing elements, all those things are really the same, regardless of what type of setting you're in. Now, over the years, AMD and experience with our clients and looking at an analysis done, a survey done by HIMSS a few years ago, you can see the different types of reasons that people have deployed telemedicine. Gaps in patient care, clearly the most overwhelming and compelling reason that organizations deploy clinical telemedicine. But adding additional services, also a huge driver. Lesser are removing patient barriers to receiving care, which is typically trying to eliminate geography, but that's a general statement. Policy cares and cost reduction. One comment on this would be that the first three are actually opportunities to create revenue. So even though cost reduction can be a small driver, the other three could be revenue drivers, okay, for the organization. Poll question number 2, if you would. For those who have a telemedicine program or are looking to implement one, what is your primary reason for doing so? And try, please, to pick one. Again, gaps in care being number 1, or one of the selections, adding additional services or specialties and subspecialties, remove patient barriers, healthcare policy changes, or cost reduction. And so the poll is open now, and we'll give folks just a few moments to respond. Very interesting. So the results are in, and you'd be quite interested to know that your results or your comments are almost mimic what the HIMSS survey came up with the exception of removing patient barriers to care really being the number 1. So the relative order is very stable, but removing barriers is number 1. Thank you all very much. So a little commentary, very general, not meant to be negative in any way, but more of a positive state of the union, if you will, regarding telemedicine and what we find in the market. Generally, the EMRs deployed do not do a great job of integrating the devices needed for clinical telemedicine. Now, that's a qualifying statement. Remember, now I say clinical telemedicine. EMRs over the last many years have done a very good job of integrating things like automatically capturing vitals and different data from devices, but those aren't necessarily the types of devices you need to do a live clinical assessment, okay? Now, that's just today's state of affairs. Hopefully that'll change in the future. A good example of what I've never seen integrated directly in an EMR is a stethoscope. So you may be able to take vitals right off a desktop vitals machine and put it into the patient's record, but to initiate a stethoscope session via an EMR, I have not yet seen. Additionally, video conferencing systems were never designed to support directly medical devices that a physician or consultant would need to do a live medical device integration in session. All right, they've tried to do different things, but they've never been designed for that, which is an opportunity, an issue and an opportunity moving forward. Additionally, almost all development that AMD has been exposed to with regard to medical devices, all the development being done for the next generation of devices are being done with PC terminated points. In other words, mostly USB and Bluetooth. Right, so that's where the medical device market is going. Lastly, non-technical, the consulting clinicians are insisting on mobility. 10 years ago, 15 years ago, when telemedicine was still at its infancy, doctors were required, because of the cost, expense, and the way things had to be deployed, to go to a designated, dedicated place to do their consultations. Now physicians are saying, I want to be mobile, just like I'm mobile with all my other applications. Now, what does that all mean? Well, and Rob will go into this in detail when he discusses what they've been deploying, the types of medicine they're providing, and who they're providing it to. But in the environment that Adventist has is not atypical in our experience as we work with clients all over the world. We all recognize the importance in the large investment that everyone has made in EMRs, and it's absolutely an imperative for continuity of care. The challenge is that there are over 800 active vendors in the U.S. market alone for different EMRs or large practice management systems. So you can understand that as a technology provider, platform provider, as AMD, the challenges of having a mechanism to easily integrate any of the information captured during the clinical assessment and be able to communicate with over 800 different vendors is quite an onerous task. So in order to have a successful program, you have to have the methodologies to do that quickly and at low cost and in a short time frame. Again, back to video conferencing. A lot of changes in that market recently, but we all have to recognize that video conferencing has been a tool in the healthcare industry for quite a long time. Now, not all being used for clinical telemedicine, but typically many organizations started using video conferencing for grand rounds, education, connectivity between different sites, administrative tasks, and things like that. So there's a huge investment in the marketplace for video conferencing. I don't know of very many healthcare organizations of any size that don't have some existing investment in video conferencing. At the same time, the vendors in the market, people that have based their systems on dedicated hardware or software applications, is really changing quite dramatically. And these are becoming more and more commodity-like moving forward, where they're sold by convenience, they're centralized services, they can be software only, the price points are coming down. So it's very important for us as a technology provider, looking into the eyes of the folks at Adventist, to be able to be adaptable to what they already have as an investment, namely in their environment, Cisco video conferencing, as well as the advent of more and more video, VIDYO deployments, and how do they work together. Mentioned also the medical device market. There is a lot of development going on, not just at AMD, but in companies and garages around the world, redefining the medical device market. And I had mentioned earlier that the USB and wireless connections dominate. Those developments are targeted to connect into the PC, Microsoft, Apple world and their data buses, not necessarily being designed into the video conferencing communications bus. So we have to look at these things and say, how can we be successful putting in a platform that can adapt to really 3 different areas? You have to be able to adapt to any EMR and do it successfully, adapt to any investment they previously have in video conferencing technology and be able to use multiple different devices from a myriad of different manufacturers. So how does that get done? Here's a typical example. All right. This is the way Adventist and many of our clients operate. On the left-hand side, you have a nurse with a patient, or when I say nurse, it could be a medical attendant with just some amount of medical knowledge and understanding of how the system works. And they're with the patient, and they have a PC, monitor, and devices from AMD or other manufacturers. When the attendant or telepresenter logs on, they do so with a browser. And when they do that, that PC transforms itself into a web server. So a strong PC with myriad of different devices plugged into it then becomes the server. It's also device aware. The software is smart enough to know that in this USB port I have a stethoscope. Over here I have a otoscope or an ultrasound or a colposcope or a vital signs monitor. I'm just showing 3 basic primary care devices here. Once that PC transforms itself into the server, it becomes a real-time cloud just in that specific exam room. The remote physician gets alerted. Now we're using an example of our ExamFlow application. That's a whole different webinar, but just let's assume the doctor knows now to connect, okay? The doctor, the remote consultant, uses also a browser. No other software required. Just the browser. Once connected, that becomes a secure link. That browser is securely linked to that server in the exam room with the patient and the telepresenter. The consultant has now direct access to stethoscope, heart and lung sounds, live diagnostics in ears, nose and throats, abdominal ultrasound, vascular ultrasound. I could go on and on. And they provide the video conferencing would be on the right-hand side of the screen typically, again, from any manufacturer, including AMD. So we're agnostic to the type of video conferencing would be used. The left-hand side of the screen would be the actual live feed from the medical device, providing the consultant with patient and medical context simultaneously. They perform the evaluation of the patient, come up with a diagnosis and a plan, and when it's all completed, what the system will do will package up any of the data that's been captured, whether it be an ECG that's a PDF document, an instructional video, an image of a mole, a recording of heart and lung sounds, package it up in one of 2 ways, HL7 and or a summary PDF, and it gets deposited via industry standard technology using HL7 messaging directly into the EMR. In the case of Adventist, it's Cerner. So this is an example of a way that we can use we can have 3 different variables within a deployment, being devices, EMR, and video, and accommodate virtually any customer situation given their existing investment. Lastly, as a summary, on the left, you see all the different medical devices and the different technologies that we can accommodate with the inbound device aggregation, it's called. On the top, the different network topologies that are supported so that you can do anything from a Ethernet 10, 100, or 1 gig environment in a large organization, all the way to the far end of the spectrum with satellite, be on an oil rig in the North Sea, and provide a medical consultation. The consultant interfaces and the nurse interfaces are all browser-based. So from an IT perspective, there's no software to download, no software to maintain on these PCs. It's just standard browser technology. The EMR, HL7, or configuration files and or summary PDF. And then in the middle, we support all the different, the 2 main interfaces for pan-tilt zoom cameras and all of the video conferencing codecs, hard or soft, that could be used to do the communication. So now I am going to hand it over to Rob
Thank you, Dan.
And
Oops, go ahead.
it's all yours, Rob. Tell them the exciting
Grateful.
things.
Well, thank you, Dan. It's a pleasure to be here and speak about the journey that Adventist Health has been on over the last 4 years with our virtual care network. And, you know, we first started off about 4 years ago, formally organizing our approach to what we called then telehealth. And over the last year or so, we've kind of changed the nomenclature a little bit more towards virtual care to encompass the full gamut of different types of technologies and services, business cases and clinical cases that as part of our overarching strategy. So for those of you who don't know who Adventist Health is, so we are a fully integrated health care delivery system on the West Coast. We have 20 hospitals serving 3 states. We have about 2,875 beds. We have more than 275 hospital-based clinics, rural health clinics, and physician clinics. Adventist Health in California owns and operates, and actually up into Oregon as well, owns and operates probably the largest network of rural health clinics west of the Rockies. So when you look at our footprint, and I'll show you on a slide in a little bit, you'll really see that most of our markets are in the rural markets throughout California, with a couple of urban markets as well. We're headquartered out of Roseville, California, which is kind of just outside of Sacramento, and we're really focused on whole person care. We started to promote healthy individuals and families, but also communities. And as most of you are probably going on a journey more into population health, social determinants of care, how to interact with the community more and be able to bring health to the communities versus just once they come into the acute care setting. So here you can see just kind of our map along California. And most of our initiative was really focused around California. We started this, formally organized, like I said, about 4 years ago. We'd been doing telemedicine, if you will, you know, with different providers in some of our different markets for several years, but never really had a system-wide approach to how we implemented this. And so we started moving this forward at that point. We started off by developing a vision, and you know, really it's the vision. The vision is who we want to be, or who we want to strive to be as we serve our communities. And it really is to support the mission, vision, values of Adventist Health by creating enhanced and expanded access to care. And going back to some of the surveys, it was really about, you know, most of you folks out there are looking for access to these patients. We want to deliver that through innovative, efficient, reliable, and cost-effective technologies. You know, as Dan has pointed out, you know, the cost of the technology has come down. The reliability of the technology has greatly increased. Bandwidth, especially for Adventist Health as a system, has greatly increased to our remote markets and our clinics and so forth. And so the reliability of the service for services that we provide has greatly increased over the last several years. So when I look at our whole portfolio of virtual care services, I really divide that into 4 major buckets. And so we started off with our initiative really looking at our clinic outpatient space. And you know, when you look at the sustainability model of a telehealth or virtual care initiative, there's really 2 business cases. One is in a rural health setting where you actually get some additional funding with your RAP payments to be able to support your infrastructure, not only for your clinic, but also for the technology that's going in to provide virtual care, to pay your physicians, et cetera. Or on the flip side to that, it's cost avoidance. And so you're reducing readmissions, you're averting that acute ER visit and so forth. So we really started off on a subspecialty play in our outpatient clinics, and we're really looking at where the carts have gone in that we've sourced through AMD, standardizing our backbone of the technology and so forth. As we look at the inpatient side, we do have stroke services up at about 9 of our rural hospitals. looking at critical care and how to deploy that again. Obviously, other specialty consults. We have an antimicrobial stewardship program with infectious disease and so forth. That is all tied into our AMD backbone technology. I also look at some of our, what I would call our ancillary and support services, or our hospital-based services. We do, as a system, have a telepharmacy that we have deployed through probably about half of our rural hospitals, as well as what we do in the future with radiology and pathology. Now the pathology has been FDA approved to do primary reads. And then I kind of throw everything into that final bucket of post-acute care services, so chronic disease monitoring. We have asynchronous telehealth in that bucket, e-consults in that bucket. I would even put our direct-to-consumer strategy in there as well, as you're really interacting with patients for a different clinical and business case, and using a different technology to be able to do that.
Thank you, Rob. Third poll question, folks. Which service areas to you see the biggest need for telemedicine at your facility? And you're free to check all that might apply. Outpatient, inpatient, ancillary service support, or home monitoring and support. Check all that apply. So the results are being tabulated. So for our participants and for Rob, 81% outpatient, 44% inpatient, 43% say ancillary service support, and 53% say home monitoring and support. So outpatient, clearly the largest need area, and then the other three significant and almost even in the mid-40s to low 50s percentage. Thanks, Rob.
Yeah, I think that kind of speaks to, you know, a couple of the earlier slides and polls, you know, removing barriers, and so those barriers are access to outpatient care, you know, and really integrating, interacting with those patients in the communities and so forth. So we really look at the triple aim, like what I described as the triple aim plus. And, you know, we all know what the triple aim is: the improvement of improved health, enhanced care experience, and reduction of cost. And for us as Adventist Health, the plus is really about our mission expansion. So, you know, developing relationships, partnerships with other rural facilities, hospitals, community hospitals, federally qualified health clinics, you know, critical access hospitals, who are just like some of our rural sites, are in desperate need of these services, but don't have access to them and can't find a reasonable approach to get there. And so it really is about expanding our mission, working with these different facilities, partnering with them in new and innovative ways. Of course, when we look at improved health, it's about staying healthy, managing risks, you know, optimizing care, and really about community health. And Adventist Health is developing its journey on population health, as well as, you know, social determinants of care, and looking beyond just the acute illness experience, but also looking into the wellness experience and understanding the needs of the patients, both socially and economically. For the enhanced care, obviously access, primary driver for our initiative. Coordination of that care is very important as well. And, you know, for us and the way we've developed our operations, to be able to actually take that patient and usher them, if you will, through the different settings of care, so they don't get lost in the system, or they're not left on their own to make an appointment that, you know, with the dermatologist that may be 2 hours out of their community and so forth. And of course, patient satisfaction and provider satisfaction, and we track those with every visit that we do. We talk about the reduced cost of healthcare. It's kind of interesting when you talk to some of the CFOs of the healthcare system. It's like when they think about reduced cost, it means, well, I can pay my providers less. And that's absolutely not the case. When we talk about reduced cost of care, a lot of that cost is really to the patient. And so, as many of you know, in the rural health community, you have these poor communities that are primarily Medicaid or non-insured communities, and they have difficulty with transportation, they have difficulty with child care, they have difficulty with taking time off work. And so if you can keep that care in the community, it really breaks down a lot of those barriers that are a real large challenge in a lot of these rural communities, and as well as, surprisingly, even some of the urban communities as well. So what we're all facing in rural health is provider shortages, access to specialists. If we can recruit a specialist to the market, we often have difficulty keeping that specialist in the market, or we don't have the volume in one specific market to keep a provider busy and engaged. And of course, referrals going out of that network. And so it's all about keeping those patients close to home, close to their families, close to where they have that support system and environment. Other challenges, obviously, we're all facing downward cost pressures and eroding margins on the hospital side. Talk a little bit about population health. Always want to focus on quality, and when we start the conversation, it's really around what is our quality story for that patient, or how do we deliver a quality service to that community. And then leveraging ourselves as a system across multiple markets, across California, Oregon, Hawaii, to reach down and be able to engage specialists as part of our network and use that specialist across multiple different markets up and down the state and the system. There has to be a value proposition, not only to the patient but also to the providers. And these are just some of those things that we've heard from our specialty providers, is that this gives them a way to increase and broaden their base of patients. It can reduce their overhead in their office practice. With our model, we have the ability to interleave a telehealth visit with a regular clinic visit. So when that physician is in his office in Los Angeles seeing patients in Clear Lake, he can jump to his clinic room, see a patient, go to his office, close the door, and be seeing a virtual patient in our Clear Lake community. And it doesn't take any additional overhead for him to be able to do that. So it really maximizes efficiency and time. As well as in some of our markets in Central and Northern California, we have a vast network of rural health clinics. In Central California, for example, we have upwards of 40, 45 rural health clinics that are spread over a 200-mile radius. And so, as you can imagine, there's a lot of windshield time with specialists driving to some of these clinics or patients driving to a centralized clinic. So it really helps reduce and maximize time. Value proposition for the patient. First one to me is obvious: access to convenient, high quality, and affordable care when they need it in multiple areas across California. Talk a little bit about, for the patient, it really reduces their travel time, expense related to taking a day off work, finding childcare for their kids, and driving to an appointment that's several hours outside of their community, if they can even get an appointment to do that. We really focus on integrating and coordinating that care across the patient's care team. And so with our care coordination center that we have set up, we coordinate all aspects of that patient's care, from scheduling to setting up follow-up appointments to setting up testing such as MRIs and so forth, to ensuring that we have lab work and relevant patient information in our medical record prior to the visit, so that the specialist actually has that information on hand. Partners in this space are key. We really started our initiative, our organized initiative, with Blue Shield of California. We've had a long-lasting, great relationship with them on many aspects. They needed a partner in the rural space, and of course Adventist Health being our primary space, we look to each other to really help augment and align in that initiative. I also put the USDA here as a partner. Obviously, there's grants, and it's not just the USDA, but multiple grants out there that facilities and systems need to look at to try and attract to be able to spread the equipment and be able to outfit some of these rural clinics. Obviously, everyone has a vested interest in telehealth and access to care, and the USDA is one of them as well. And the California Medicaid program, there's multiple strategies around Medicaid expansion, and at least in our current healthcare environment. I don't know what the environment is today, I haven't heard yet, but in California we've had that Medicaid expansion program, and so that has really kind of helped propel our access in the space as well. Some of the keys to success, we talked a little bit about the vision and developing a direction on how to get there. It's key to developing a strategic plan that clearly outlines what specialists, what clinics, what technology, how you're going to implement. Training is a significant piece of that, not only for the provider and how to be a virtual care provider, but especially for the clinics and how the medical assistant in that clinic interacts with that patient a little bit differently. Aligning across the enterprise, so in our case it was a rural health strategy, the different payment options in California, and as I indicated earlier, it's fee-for-service in a rural health clinic, but we're also aggressively getting into managing more risk in some of our markets in our northern and central California. And so when we start managing that whole population and go upstream on the payment, virtual care makes an awful lot of sense and makes it a really strong business case as well. Buy-in, extremely important. So for us, reaching down and working with our CEOs of the different markets, and we have 4 different regions throughout our company, but multiple CEOs, 20 CEOs of the different hospitals, making sure that they are engaged, that they can help drive this, that they support it. They understand their unique physician relationships in the market, so they help navigate that. They understand who their high-quality providers are in the market or where their patient needs are the most and so forth. And so really engaging them to help drive the strategy is very important. Clear communication, I can't overemphasize this enough. It's communicate both internally and externally. Just when you think that you've reached everyone, you've inevitably forgotten someone that you need to communicate with. So developing a clear communication plan is important. Focusing on specific clinical problems. So what are you trying to solve for? Is it access? Is it a certain specialty need? Is it, whatever that need is, it's really defining what problem it is you're trying to solve. And then, of course, measuring your success with data. We're not quite at the point yet, but, we want to get to the point where we can actually start measuring the health outcomes of a community or a population, and the effect that virtual care has had on improving the health outcomes of that population. So I talked a little bit about our operations center, and so it really operates as a virtual multi-specialty physician practice. In California, we can't own physicians, we can't employ physicians, so we have physician partnerships like foundations, medical foundations, and in this case we use an independent provider association, IPA, to align our physicians to provide telehealth. And basically we don't own it, but it's a friendly IPA. And the MSO, or the Care Coordination Center, provides services for that IPA. So it's tightly aligned in what we're doing with the providers and how we schedule and coordinate that care. And so these are just a list of things that the Care Coordination Center, services that they provide. So this is the equipment. So one of the first things we did almost 4 years ago now was determine what type of equipment to put in the clinics, and really that was basically determined on what the clinic's needs were. So this is actually a picture of our carts that we've deployed in our clinics, with the exception that it has actually a vital signs monitor on it. So we've had a high definition camera. The nice thing about this dual monitor setup is that you don't lose visibility with the patient when you plug in the peripherals. You always have an eye on the patient can see you, and on the second screen you can see the peripherals as well. And the physician from his remote site can manipulate the camera, can zoom in, can pan, tilt, and zoom. So very nice setup. Everything on the left side of the screen is the Agnes software that basically brings all the peripheral data in, and we've worked closely with our partners AMD and Cerner to develop that interface so that now everything that happens on the cart or is captured by the cart is now transferred into Cerner as our electronic medical record and housed there as the patient's permanent record. And all of our physicians, we're a Cerner shop, both on the acute side and the ambulatory side. All of our physicians in the virtual care realm document within Cerner as part of their workflow. This is what the provider station looks like. It's a very simple setup. Camera, again, we recommend dual monitors. We have a couple stations at a couple central places in Bakersfield and in Glendale, which is one of our largest hospitals in the system. But we've also deployed this in private physician offices as well. So again, they can bounce back and forth and see patients from one to another. We provide a lot of support on these visits. We have someone sitting with the physician at least for their first few visits until they get comfortable with the technology, and we also do that on the other side as well, on the patient side. These are our current locations, some of our clinics that we've set up. We received the USDA grant in 2015 for an additional 10 carts throughout our system. We're deploying that, and we've just applied a couple of weeks ago for an additional 19 carts through the USDA. So we'll be able to expand this, and the second grant really gets us up into Oregon in our hospital in Hawaii. So what have been some of our results? And so we basically started from scratch, like I said, about 4 years ago. Didn't really have a lot of data from some of the things that we were doing. Our partner with Blue Shield, our initial go live was to set out 25 carts. 16 of those were to be in Adventist Health owned facilities, and the remainder of those to be in relationships that we built with FQHCs or other rural health clinics or systems. And just a point of interest, so when we started this, we had a very, very short time frame to get this up, and so 25 clinics with 13 specialists. We got the first 10 in 13 specialists up from scratch within 3 months. I wouldn't recommend doing that. That was a tremendous amount of work. Obviously, there's gaps in communication when you push it out that fast. And so I'd recommend really focusing on one specialty, one clinic, and developing the processes around that, and then being able to expand that. We've seen a lot of growth and support for behavioral health and psychiatry in our Northern California market, and that was a real key focus for us in 2016. We've increased our volume significantly. We started off, 2015, I think we did about 2,000 visits. We ended up the last year at 7,500 visits. We also have a relationship with the California Department of Corrections, and so that factors into that as well. And this year we're well over probably 11,000 visits, on track to do 11,000, 12,000 visits this year. So we've seen a tremendous amount of growth, and it really is about how we've integrated better and communicated better in our ministries as we've laid this out. And this is just a dashboard that we track on volumes. So we can slice and dice the data by clinic, by specialist, by physician, pretty much any way that we want to look at it. So what can we still improve? We're constantly on a journey of improvement. I don't think this is something you necessarily ever perfect. The only constant, I think, in healthcare is that there will always be change. And so as change happens in our environments, we move to meet those changes and challenges. So we continuously try and improve on market communication, how we integrate with our ministries. how we integrate with physician leadership in those ministries, and having point people from the administrative side to be able to help drive some of this success. Project management is key, and project planning as we roll this out. Many different types of inpatient strategies. We're seeing a huge demand now with our own in our own system for non-emergent acute services such as general neurology and so forth. Training is a critical piece of setting up any program. Having, you know, the right staff trained at the clinics that know how to use the equipment, that know how to engage the patient, know how to sell, if you will, a virtual care visit to a patient to make them feel comfortable that this is the same level of care that you would get on a face-to-face visit. The only difference is the vehicle by which the physician is coming in. And so the video component should be the only difference in the standard of care that you're delivering. Clinical protocol is very important, strong physician leadership, provider engagement both on the referral and the provider side, and constantly evaluating new technology. As Dan alluded to early on in his presentation, this is probably one of the fastest evolving fields that we have in healthcare right now. Technology is continually advancing. There are many vendors that are popping up with kind of the latest and greatest gadgets, if you will, sometimes that I think still has a lot of proof that needs to be proven out as far as its clinical efficacy and clinical benefit. So it's just something you continually watch and look at and try to improve on. Just some of the things that we would do differently. Sometimes I feel like we have been building the plane in flight. I think we've stabilized that over the last year and a half or so, but really getting the program up and going in such a quick time frame was a challenge. And to do it all over again, I would take a much more structured approach and set it up in a different cadence than we did. But we had some very aggressive timelines to meet some very aggressive objectives, and we did what we needed to do to advance the program. And that's all I have. Any questions?
So if any of you have questions, just a reminder to type your question into the box on the right-hand side on the control panel. And on the screen now you'll see, we'll put up the contact information for each of the presenters in just a moment as we go through the question. Just give me a few minutes to look at the questions. Okay. The first question could be actually Rob or Dan, you could answer this one, is it necessary for the MD site to have 2 monitors? Do you want to take this one, Dan? Or?
Sure. No, I think it's a matter of choice, and perhaps depending what video conferencing system you might choose. So if you have a self-contained hardware dedicated video conferencing monitor, then that naturally would be one of the 2 monitors you'd use, so that on the other one you could have live device information and your EMR to chart in. If your video conferencing is a software based, then you could combine those all in one monitor. But a lot of it is personal choice for the physicians. And then Rob, I'm sure, has an opinion on that based upon his user experience.
Yeah, no, I agree. And so for our applications, we obviously use a video component. We use the Agnes component for the peripherals, and they have open their Cerner outpatient ambulatory program. And so you can just as easily minimize screens as you're kind of going through this. It's, our providers, prefer the dual monitor. It's more convenient, but you can definitely do it with one.
Okay, thank you. Rob, before, did you compare the EAMD carts versus building your own telemedicine cart?
We took kind of a brief look at that. We worked with our IT folks, and there were different relationships they had with different components, such as Cisco, for example. We use Cisco for our telecom systems throughout the system and so forth. we felt that using a provider like AMD who could help guide us and has the expertise to be able to really develop a robust, reliable cart was the way for us to go, especially since this was relatively new as far as putting carts in clinics. We did use, the Cisco bridge because of the relationship, I think, with Cisco and so forth, but really, it wasn't much of a decision for us to go with AMD. It seemed to us to be a no-brainer.
This one's for you, I think, Rob, as well. With such a shortage of behavioral health providers, how have you overcome this to be able to include this as a service and meet the IP and OP needs?
Great question. I don't think there is a market anywhere in California or probably anywhere in the United States that behavioral health doesn't pop up as the #1 need. The technology part is relatively easy both on the inpatient and acute side. In fact, if you look at behavioral health on the outpatient side, you really don't need peripherals. It's a video conference. It's probably the easiest thing to set up. Finding the providers is the challenge, and so we've taken a multi-pronged approach. We have behavioral health specialists such as psychologists. We have some of the psychiatrists that we already engage in some of our clinics on face-to-face visits, set up on a network in doing some of these. So we're using our own physicians and our own providers to help. For a second phase, we partnered with other organizations. We have a sister organization in Loma Linda University Medical Center, large academic Adventist Medical Center down in Southern California with a very robust psychiatric program. We've engaged them as our provider partners to help with some of our outpatient needs, and it benefits them as well because we can incorporate their residents and residency program into delivering the care. And then on the acute side, we are looking at a couple of different partners to help with some of those acute needs, so the ER visits and so forth. So for us, it was a multi-pronged approach. I don't think we have one provider that can serve all those needs.
Okay. Rob, what is your support model for the telemedicine program? Is it 24/7 ad hoc or scheduled consults?
So for the outpatient side at this point, it's scheduled consults. So we schedule through our care coordination center. We try and get the patient scheduled within 48 hours of appointment request. As we look at, our next initiative, which is the direct-to-consumer, we're actually finalizing a relationship with Teladoc. It'll be probably a hybrid of scheduled and on-demand, and we'll probably tap into their provider network to be able to help with some of the on-demand work.
Okay. Rob, what do you see as the biggest wow factor that you believe will come to fruition in the next year or two?
Wow, that's a very good question. For us, it's going to be really, as we look at develop our population health strategy and really dive into at-risk populations in some of our markets, I think that we're going to be using asynchronous technologies as a system more and more. So, we have a relationship with BrightMD, for example, at some of our clinics that we just went live with in Northern California. And so it really is that asynchronous. I'm going online. I'm just kind of typing in some of my key complaints. And on the other end, you'll have a mid-level or a primary care assessing that and giving feedback, either prescribing or triaging that patient to a different level of care and so forth. I think we'll probably see more and more of that. I call that, basically convenience care. So now I don't have to go into my physician office to get a refill. I can do this kind of online, and we can have that online interaction of how I'm doing and so forth. So I think that's going to grow in the wellness space pretty dramatically. But I honestly think that there's always going to be a place for what we're doing in the clinics now with the peripherals, and the video components, and of course on the post-acute. So there, like I said, there's there's going to be multiple technologies for the different clinical and business strategies.
Okay. What is the minimum bandwidth to assure the reasonably good exchange of information and videos? Dan, do you want to answer that one?
The minimum or sweet spot for the bandwidth should be 2 meg. You can have different options where you can lower that and have that to about 1, but for a reasonable balance between quality and bandwidth, it would be 2 meg.
Okay.
And I would just add up and down. So because of the way the technology works, you want to have that same ability up and down, symmetrical.
Thank you. Rob, how do you track the flow of referrals from multiple clinics to see what the target area is?
So we obviously track our referrals into the clinics, and so we know which clinics are seeing what type of patient in the specialty. I'm not sure I'm catching the last part of the question, though.
So what measures do you, let's see, hold on. How do you track the flow of referrals from multiple clinics to see what the target area is?
Well, part of our care coordination center is tracking all of our referrals, and by that, and I think the last grid that I showed, kind of our dashboard, we can take one clinic and we can determine what types of referrals came out of that clinic and what volume compared to as a whole. And so, or we can take psychiatry, for example, and we can slice the data so that we can see what our top 10 clinics are for that certain specialty. So that's the beauty of the Care Coordination Center and the data that they are able to gather and working out of our Cerner system to be able to develop matrices around that.
Okay. Dan, this question's for you. Does AMD work internationally or just in the USA?
No, AMD has been a global company almost since its inception. We actually do about half of our business outside the United States as compared to North America. And we're currently in 98 countries, soon to be 99, knock on wood.
Okay. Rob, are the telemedicine cards necessary for your behavioral health consults?
Probably not the cart at the size that I showed you there, but we have a couple different methods for the behavioral health consult. So we'll have just a monitor on the wall with the video component attached to it, or we will have a mobile cart with a video, but we don't need all the peripherals and the advanced cart. And so, you know, you'll scope your cart based on what your needs are for that specific clinic. So no, we don't need all the peripherals to go along with it, just the video component.
Okay. And follow up to that, what platform do you use to connect patients with the providers?
So we use Video, VIDYO, as our video conferencing platform, and we have a Cisco bridge that sits and kind of connects that.
Okay. Okay, one more question on, let's see, for you, Rob. You mentioned that training requires continual improvement. Is there any aspect of telemedicine that would be desired for recent healthcare graduates? Let's see, I think that, let me see, there's more to the question. For example, would a course in telehealth techniques help prepare them for Adventist Health? I think it must be a student asking some questions about preparation to work in the industry.
Yeah, so is this from a physician standpoint, I wonder? So from a physician standpoint, I'll address both sides. So, you know, I think slowly we're starting to see virtual care slowly entering into some of our residency and physician training programs, especially as, you know, the younger physicians come out of training, they're more intuitive to technology and they seem to migrate to that quite a bit more. Although in the past, this really hasn't been taught, and quite frankly, it is a little nerve-wracking for physicians just from an engagement standpoint, use of technology, and also from a malpractice, med mal perspective. But now that's starting to change slowly, I would say, but it is starting to change. On the other side of it, there's not any programs that I'm aware of. We've developed some online competency and training. We have training courses that we bring our clinic staff actually to our corporate office for 2 days of training, and then we have developed online competencies that they can refresh and so forth over the year. In fact, we just finished, as part of our USDA grant from last year, finished shooting a whole video series training on how to be a presenter and what it means to telehealth and so forth.
Okay, thank you. All right, it's 4 o'clock. We want to be respectful of your time, so we thank you for attending, and Dan and Rob, thank you for your thoughts and comments on the technologies and programs. We will be sending out an archived version as well as a copy of the slides within the next 24 to 48 hours. You'll receive a link, an email with a link to that information. Thank you for attending and have a good day.
Thank you.
Thank you, Carrie. Thank you, Rob.